Hello, Torrance Festival of Ideas, listeners, watchers, viewers, and participants. My name is Lisa Renzi Hammond, and I'm going to be your storyteller today for A Tale of Two Grandmothers, How a Promise Made is Changing Alzheimer's Disease Diagnosis and Care in Rural Georgia. Now, I am presenting on behalf of myself and my partner in crime, Dr. Janae Beer, and I will introduce us both momentarily. Today in our conversation, I do want to call it a conversation because even though I'm not there with you live, I deeply hope that over the next few minutes, what you hear from us essentially causes you to think differently and to challenge the dialogues that you hear around this topic. So my name is Lisa Renzi Hammond. I'm an associate professor of neuroscience, and I'm here in the College of Public Health at the University of Georgia. I'm an associate professor in the Institute of Gerontology, and I am also the interdisciplinary group lead for behavioral and cognitive neuroscience in our Office of Research based sort of integrated life sciences interdisciplinary neuroscience program. Now I'm presenting on behalf of myself and Dr. Janae Beer. And Janae is also faculty over here in the College of Public Health. She's with me in the Institute of Gerontology, and Janae has a joint appointment in the School of Social Work. So this is us, but this is not all there is to us. There's a bigger story here, and you'll see that theme sort of coming right throughout our presentation. So let's start with chapter 1, which for us, unfortunately, was a paradise lost. Let's turn the page and see if we can figure out what we mean by that. So on the left-hand side of your screen, you are looking at a radiant woman. That is Evelyn Hayes, and Evelyn Hayes was my grandmother. When I was a little girl, Evelyn always wore the most beautiful sparkly things. And to my very, very young eyes, those sparkly things were the most beautiful things I had ever seen in my entire life. I was like a magpie. I would sort of collect all the sort of shiny objects that she would give me, little trinkets, little tokens that were as sparkly and radiant as she was. My grandmother used to call me Honey Bunch. That was her nickname for me. And that beautiful fire engine red hair that you're seeing there was her fire engine red hair her entire life. My last memories of her essentially had that sort of vibrant hair. Now on the right, you are looking at Grandma June. Grandma June is Janae's grandmother. So just as Evelyn represents the start of this story for me, June represents the start of this story for Janae. So June was also a radiant woman, and she was clever and she was witty. You can see her holding Janae when Janae was just an infant, just as you can see my grandmother holding me. You see, if you had to describe either of us, we would have told you we were grandmother's girls. We grew up with these sort of strong women in our lives and were completely moved by and influenced by them. So at age 80, my grandmother, Evelyn, was diagnosed with Alzheimer's disease. It had been coming for a while. We sort of saw small, subtle changes, and we'll talk about those today, that signaled that there might be a problem. And then it got worse and worse and worse. My grandmother lived for 10 years after her diagnosis of Alzheimer's disease. She died at age 90. On her last visit to my house, she didn't know who I was. She repeatedly introduced herself to me and said, "Hi, my name is Evelyn." And so of course I simply said back, "Hi, my name is Lisa. It's nice to meet you." Because at that point, I know that her representation of me as her granddaughter would have been a very, very little girl. And she looked at me and said, "I know I don't know you, but I feel like I could trust you." So at that moment, I thought to myself, okay, I think I need to do something to become worthy of that trust. That was the moment where my career trajectory shifted a bit away from just trying to understand brains to trying to change them. Now, Janae's experience is similar, right? This sort of beloved human and these changes that are big, that are sweeping, and that are hard to reconcile. June did not live with Janae and with her family. June lived in a different place. So the family, Janae's family, would call June very often on the phone and check in as grown children do. And June would say, "Nope, I'm fine. Everything's great. Everything is fine." And then one day a neighbor called. Everything was not fine. There was no food in the kitchen. Expired food was about all that was present in the house. June had been robbed. and scammed. And that was the day June came to live with Janae and her family. Janae has lots of wonderful memories of that time, providing care for June, but also has a set of memories such as, I was the person who would go whenever June would wander. So we both decided in those critical moments of our lives that, that the life that we knew, that we understood as loyal granddaughters to our grandmothers was forever different, but that at least our grandmothers had us. They had family who understood what they were going through, who tried their best to help. So although it might have been a paradise of childhood, that had sort of been lost for us, we each vowed in that moment that we would make a promise, right? That we would treat this problem differently, that we would dedicate our lives to making sure that others in the world did not have to experience the same pain that we did. So for those of you who are approaching this topic for the first time, and you might be curious about what dementia actually is. So the Alzheimer's Association has done a wonderful job of creating infographics like this one to give us a good context for thinking about dementia. You see, dementia is an umbrella term. It refers to loss of memory and other cognitive abilities that are severe enough to interfere with daily life. Not all of them are terminal. Alzheimer's disease represents about 60 to 80% of those cases, but more and more often now we're seeing individuals with Lewy body dementia. We live in the stroke belt here in Georgia, so vascular dementia is something that we see very consistently. We're seeing aphasias and frontotemporal dementias. And of course, here at the University of Georgia, we have a lot of research infrastructure dedicated to studying diseases like Parkinson's disease. Now, dementias are not one size fits all, and we often see people with more than one. For example, about 70% of people who report to us with vascular dementia who've had a stroke or some sort of other issue like that also have Alzheimer's type dementia underneath. So one of the most common things that we hear people say when a loved one has Alzheimer's disease is, look, if my loved one could just understand, if my wife only knew that she just needs to stay in bed at night, if my husband only knew that he shouldn't drive his car, he can do anything else, just don't drive your car. And we have to explain the reason that your loved one is having a hard time understanding those things is because Alzheimer's disease fundamentally is a radical change in the way the brain is able to process information, right? It is not the case that we can sort of miraculously make our loved ones understand what is going on when they do some behavior that we think is dangerous to them. So it helps to sort of understand why we get Alzheimer's disease, because again, there's still a lot of stigma out there in the world. And if we're going to understand how to do a better job of dealing with folks who have Alzheimer's disease, of preventing the disease, of talking about it and making life better for our care partners, then we have to understand where it comes from. Now, there's a set of non-modifiable personal characteristics that we always discuss, like your family history, your age, your very genetic makeup, your race, your ethnicity, your gender, those sorts of things about you that we tend to think of are pretty concrete. But notice my asterisk on this slide. Non-modifiable is an interesting concept, right? If we say non-modifiable, then we might not actually be talking about things like gene expression, simply because the more we learn about epigenetics, the more we understand that your gene expression is a modifiable thing. Yes, the hardware that you're born with, right, your actual A's and T's and C's and G's that make up your genetic code are in fact pretty well set. But of course, which of those genes is switched on or switched off and how the environment impacts that gene expression, that's an emerging topic of study for us. So I put a little asterisk by non-modifiable. Sometimes we attribute too much to family history. So we say to ourselves, oh my goodness, my grandmother had Alzheimer's disease. That must mean that I'm headed that way. But of course, behavior also runs in families. If I were to ask you to close your eyes and think of the food that you most want to eat when you are in emotional distress, you might pick something that is close to you in your culture, right? So for me, that would be chicken cacciatore from my grandmother from Italy, who is no longer with us. It was the very thing that I asked for when I told her that I had successfully passed my comprehensive exams. And she said, I would love to do something for you. What would you like most? And I said, a pot of chicken cacciatore. It was the last pot of it I ever ate. And it was the thing that was most special to me, right? So our habits tend to run in families. We behave very much the way lots of folks in our family behave. So as we think about these non-modifiable personal characteristics, we might need to think about them differently. And that being said, the bulk of the incidence of Alzheimer's disease can, we think, be prevented. We have to do a better job of managing our medications. We have to watch the sorts of foods that we put into our body. We have to control our cardiovascular health. We have to engage in radical cognitive novelty. And all of you who are listening today are doing that. You are exploring new ideas, new tropes, new paradigms, different ways of doing things. We definitely need to worry about things like physical activity. We need to curb smoking for sure. We have to try to avoid stress, to get enough sleep. It's all of the same behaviors that you would have thought of if I were to ask you, how would you do things to improve your health? Except that I think most people say those things without really deeply believing and embodying the fact that, yes, that is exactly how you do it, because all of those behaviors will radically change your physiology. So I could give you a presentation on any one of these prevention items. I could tell you the science behind why it works. But either way, the truth of the matter is that despite our best efforts, we can't always prevent it. The disease is still there. So if you were to ask older people, as the AARP often does, what is it? If you had to tell me something that you were afraid of about older age, we hear things like financial loss, we hear things like cancer, and we hear things like this: fear of Alzheimer's disease. You are looking at items appearing on your screen from an actual survey that measures fear of Alzheimer's disease, right? A recent national survey of adults aged 50 to 64 years found that that's it. That's the fear. That's the thing that people are really afraid of. It's being diagnosed with dementia. You might see yourself in some of these items, believing that developing Alzheimer's disease would be the worst thing that could happen to you, or saying that you'd rather have a painful physical illness than Alzheimer's disease, or that you have this deep fear of not recognizing your family members. As you watch this, if you are an older age, you might start thinking, oh my gosh, I misplaced something. I forgot a name. Does that mean that I have Alzheimer's disease? Right? This is a really big question. So one thing that we hear a lot is the question of what is normal anyway? And the answer to that question is that normal is a statistical concept, right? It doesn't necessarily mean that what is normal change for someone else is not normal change for you. So we're going to explore that in just another minute as we progress through chapter 2 of our discussion of our Tale of Two Grandmothers, which is Much Ado About Nothing. It is trying to answer the question, what is normal? And the answer to that question, what is normal, is that it is normal that brains change with time. They absolutely do. If we were to compare younger adults and older adults, just looking at the volume of brains, right? Just looking at gray matter, which is the cell bodies, the kind of machinery of the cell that keeps the cell alive in the brain, or white matter, which is connections between brain cells or different or neurons in this case. If we look at the ratios of gray matter and white matter in older people and in younger people, yes, it is true. Brains change with age. We lose gray matter and white matter as we age. Now, if we start thinking about sort of what that looks like and we break it down by different ages, what we can see is that obviously loss accelerates after middle age, right? That we sort of hit a nice plateau point and then our trajectory looks down. So you can see gray matter on the left and white matter on the right. And we see these trajectories, they're going in directions we wish they weren't going. But that doesn't necessarily mean that just because we lose real estate in our brains, that we lose the ability to function. And far too many people view older age as being a loss of function. And it is not necessarily. In fact, older people come up with wonderful neurological strategies for dealing with loss. So if you were, for example, to give a task to a younger person and scan brains while this was happening, what you might find is that young people are annoyingly modular, says the middle-aged woman who is speaking to you now. Meaning that when I watch my own kiddos who are capable somehow of simultaneously having a conversation with me, doing their homework, eating food, and listening to music all at the same time, and I think, no, you need to focus. How are you doing all of that? That's not right. What I end up finding out is that they can do all of that. They can effectively have this conversation with me while doing these other things because their brains are profoundly modular. They don't need to use a whole lot of real estate to actually end up getting the right answer to the problem. If you look at older people and give them the same tasks that you give younger people, what you tend to find out is that older people are starting to bring in other regions of brain for support. In fact, if you look down there at column C and you look at the various regions of overlap between younger brains and older brains when a problem is being solved, you'll see that it's not that significant, right? That older people are using different strategies to enable them to actually do the job. So if you were to try to map those strategies, right, there's a couple of hypotheses that say that older people start pulling from both sides of the brain to answer a specific question, or shifting their processing and direction. However you take these data, what they suggest to us is that as the brain senesces, as it ages, older adults tap into resources not usually used to solve that particular problem. And by doing so, they keep function as high as they possibly can for as long as they possibly can. That is normal. In the case of dementias like Alzheimer's disease, what we're suggesting is that decline exceeds the ability to compensate. So perhaps the trick to cognitively aging with grace, again, says the middle-aged woman who is entering that sort of slope that we just saw, is to bolster cognitive reserve. So if you think about what cognitive reserve is, it is all of those protective factors that you do that change the way your brain actually compensates and ages. On the positive side, remember all of those things that I just mentioned in the prevention slide. Every one of those behaviors is associated with building cognitive reserve. So if we take a look at some of these protective factors, it's things like mental stimulation. Right now, you have just taken an hour out of your day to come and learn something that I hope is quite new to you. If I had imaging equipment sensitive enough to measure you, and I measured you before attending the Torrance Festival, and then I measured you again afterwards, if I had imaging equipment that was sensitive enough, I would start to notice small scale changes in your brain milliseconds after you hear new information. Right now, in this moment, you are participating in mental stimulation and building cognitive reserve. Wasn't that easy? Now, when it comes to maintaining an active lifestyle, brains need blood. If we can push blood up to the brain by physical activity, we do wonders. But not only that, when we exercise, we reduce stress, which is one of those things that is a negative factor that limits cognitive reserve. We need social stimulation. I told you that I very much hope that this became a conversation for you, that simply engaging with this material causes you to think differently about the subject and to talk differently to others as a result. But the sort of important point about that is talking to others, right? In our world, we live in a state of affairs where we have not been doing enough of that lately, unless it's over Zoom, as you are seeing me right now, which is less than optimal. And then, of course, as we start going through these various features, doing more of these things builds cognitive reserve. Now, we want to do less of the things that are on the other side of the screen. Education matters. Individuals with lower access to education tend to have poorer cognitive reserve. Mood disturbances and stress, poor nutrition, alcohol and drug abuse, poor physical health. These are the things that will limit your cognitive reserve. So when it comes to Alzheimer's disease, yes, our brains change over time, and it might be the case that at some point we get old enough, and this is the scenario I'm hoping for myself. I don't mind if I get Alzheimer's disease. I'd like to be about 118 years old when that happens, though, right? So what we know is that at some point we are going to decline, but the goal is to change the trajectory. Individuals with lower cognitive reserve, that you can see at the dashed line, start making that downturn, that lower inflection faster, earlier in their lives. When we look at folks with higher cognitive reserve, we see they go a lot farther because of that compensatory availability before they start making that slide down. If incident dementia occurs at the red bar, right, we can see that those individuals with lower cognitive reserve, if this is time, would actually start showing signs of neuropathology earlier than individuals with higher cognitive reserve. If you think about the sort of freakish strengths of older people when it comes to cognition, everyone always focuses on the red line, which is a decline in fluid intelligence and problem-solving ability that we expect to have happen over time. However, you see that yellow line? It doesn't change. That is your culture and knowledge-based intelligence. Older people who have been around for longer and who have engaged in more experiences may have different problem-solving algorithms because they've tried it before and they know what works. The intelligence of a human when it comes to knowledge is limitless, and it does not change with time. So In this scenario that we have been discussing, we have normal expectations for cognitive function. We know there will be a downturn. We know that brains change with age, but we also know that there are things that we can be doing to maintain functional normalcy. But our story has a chapter 3. And for some of you who are watching, Still Alice would be a worthy title of our chapter 3. For me, it's Still Evelyn. For Janae, it's Still June. At some point, we have to try to tackle the question, what is not normal? Alzheimer's disease is not normal cognitive aging. It's changes in memory, planning, difficulty completing tasks, changes in mood that far exceed what we would expect anyone to undergo as a result of simple, normal aging. So let's look at some of those signs and symptoms. And if this hits home to you, fear not, because our story has a chapter 4. So if we're looking at that first symptom, which is memory loss that disrupts daily life, forgetting recently learned information or important dates of events, repeatedly asking the same questions, those things are indicative of a problem. But a normal age-related change might be sometimes forgetting something, but remembering later. We've all had that phenomenon where we've been watching a movie and we say, oh, that actress, oh, I know who she is. I'm thinking, and the name just escapes us. And then we always joke and say, at 2 o'clock in the morning, I'm going to sit up and remember the name. And often we do. That happens to everyone. When we're to the point where we're repeating our questions every few minutes, right? Or we're forgetting things that are really key and really important that we've recently learned, or really key dates and events that are special to us that we've always known, that's when we have signs of a problem. If you are caring for someone who you suspect might have a problem, you might notice that person relying on you a lot more for tasks once accomplished independently. What about challenges with solving problems, right? An example might be of normalcy might be an occasional error when managing a bill or a household finance. Goodness knows I make more than occasional errors in that domain, but not being able to follow a plan, having a hard time concentrating, and being so frustrated when a problem arises because you know it was something that you used to be able to do in the past. That would be examples of a problem. What about difficulty in completing familiar tasks? So a normal age-related change in this respect might be having trouble with a new technology. I will give you an example of my own. For the bulk of my life, I was a PC user, a Windows PC user. I knew how to problem solve, I knew how to troubleshoot. And then I decided that it would be lovely for my brain if I tried to learn an entirely different operating system. And I switched to becoming a Mac user, mostly just for the cognitive novelty of it. And I spent an entire month in a state of trouble and frustration. And I still have some difficulties troubleshooting problems that are very Mac specific. That trouble understanding new technology, my teenagers switched and could switch instantly. They didn't have that month of struggle that I had, right? That's a normal age-related change. A non-normal age-related change would be finding it difficult to complete a task that used to be easy, getting lost while driving to a familiar place, having a hard time, forming lists of things that you need to remember, right? Like a grocery list, having a hard time remembering how to use the washing machine or the dishwasher, things that are normal and familiar to you. What about confusion with time or place? In this case, it's losing tracks of dates, seasons, the passage of time. Trouble with orientation, sort of not understanding when something is currently happening versus something that happened in the past. Becoming confused about how you got to where you are. I think we've all had a distracted drive and gone home and gone, oh my gosh, I remember so little of that drive. That's really bad. But it's a very different issue to arrive somewhere and go, where am I and how did I get here? A normal age-related change might be getting confused about the day of the week, but figuring it out later. And goodness knows that a stressed out brain in this room has done that a time or two. So we can have some difficulties that arise with age with our sensory systems, like developing a cataract, something like that. That's perfectly normal. In fact, if you live long enough, you will get cataracts. But being thrown off balance, having problems judging distance and contrast that don't seem like they're related to an eye issue, these are the sorts of things that might signal a brain issue instead. What about new problems in words or speaking or writing? Individuals who are experiencing dementia may have a hard time grasping for words, forming words, following or joining a conversation, calling people by the wrong names, and having a hard time, sort of associating a name with a face. But a normal age-related change is just having a hard time finding the right word on occasion. How many times have we had those moments where we say, I need the thing, the thing that I have to put in the mailbox, the bill, I need the bill, right? You get there in the end, but a new problem would be not getting there in the end. What about misplacing things? I can tell you without turning my head or cheating and using my video system that my keys to my office here at the University of Georgia campus are clipped to my purse. I can tell you that because I lose things easily. And if I don't put my things right back in the exact same place, yeah, they might just be gone. It is not uncommon to occasionally misplace things. It is uncommon to put things in unusual places, right? And have that sort of weird, strange place where you just put your shoes or that bag of peas not correspond to any place a shoe or a pea would go. If you're pregnant, I'm going to give you a pass though, because goodness knows. So it's hard, I think, for a lot of people as we age, we have a hard time judging, is that a normal change or is that not a normal change? Because we might occasionally misplace things. We might sometimes put things in bonkers places, and that's not a sign of Alzheimer's disease. When it happens very frequently, it might be. What about poor judgment? The places we see problems most often are things like poor judgment when dealing with money and paying less attention to hygiene and grooming. Again, moms, you get a pass. But when it comes to poor judgment and dealing with money, right, we often see that older people with Alzheimer's disease are victims of scams. You heard the story of Grandma June, right, from my partner in crime, Janae. It's hard, right? We do see it's painful to watch. Sometimes people with Alzheimer's disease and with other forms of dementias being victims of scams. It's not Alzheimer's disease to occasionally make a bad decision. What about social withdrawal? I think we're all reestablishing what normal looks like in the wake of the pandemic, and it is normal to kind of not always feel interested in family or social engagements. What's different is withdrawing from social engagements because you lose your confidence to engage in a social function, right? That feeling of, I can't go to this. What if I'm incontinent? What if I have an accident? What if I can't follow the conversation? What if I need to sort of back out? What if I don't know what they're saying or who they are? That is a problem. And finally, changes in mood and personality, right? Becoming confused or suspicious, becoming depressed or angry, fearful, right? We tend to, when we are scared, react very, very seriously. It's normal to be upset or irritable when your routine is disrupted. It's not normal for situations like that to cause depression, suspicion, anger, right? Those are pretty extreme emotions. So some of you are connecting all of that information back to our fear of Alzheimer's disease scale, and you're worried. Some of you are dealing with a loved one, and what I just presented to you really hit home. So let's move on to chapter 4. We've titled it North and South, and you'll see why in just a moment. So in chapter 4, we're going to answer the question, what does one do next? And sadly, the answer is, it depends on where one lives. But our radical idea that we are here to share with you today is that North, South Georgia, doesn't matter. We will find a way to get you covered. So let's take a look at Georgia. This is 2021. It's in my head still kind of 2021, so let's just go with it. In 2021, Georgia, with its 159 counties, had about 118 of those counties that were designated rural or with populations below 50,000. I want to tell you this because when we start talking about obtaining a diagnosis and figuring out what to do next, that sort of rural versus urban divide, we tend to see being important and meaningful. So in Georgia in 2021, Georgia was ranked 50th in healthcare for older persons. Now we are up a rank. In fact, there are 51 slots on the Medicare list because DC is considered separately. So we are in fact up one this year, but not to a great spot, right? We're still 50th. We are, if we start tallying the numbers for Medicaid expenditure for Georgia, we're talking about $1.3 billion in Medicaid expenditure for Alzheimer's disease and related dementias. There has been a nearly 40% increase in ADRD incidence since 2018. So we've seen about a 40% jump in our cases in just the last few years here in the state of Georgia. Now, not surprisingly, we have seen an increase in our expenditure, and we are projected to continue to see an increase in our expenditure. Alzheimer's disease and related dementias, Medicaid costs are expected to increase by about another 40% by 2025. And let's talk about those of you who are caregivers. In 2021, Georgians provided about 600,000 hours of unpaid care for their loved ones, valued at about $7.5 billion of time. Caregiving is hard. Being someone's care partner means that you are in it for the long haul, but that it is a occasionally very upsetting situation, right? It's stressful. In 2021, Georgia's caregivers spent about an extra $300 million on their own healthcare expenditure to deal with stress-related medical conditions that arose as a result of what they experienced when caregiving. So we said north and south. Let's talk about our state from the north all the way to the south. If you were to ask me, Lisa, if you were queen, I'm not, but if someone were to say, if you were queen, what would you do? And I would say, I would make sure that adults started to discuss their cognitive health with their doctors right around age 45. We're seeing an increase in the number of early onset cases. And if we don't start having those conversations about our cognitive health, just like we should be having them about our mental health and our physical health, then we're missing something. In Georgia, when this report came out, this is from the Georgia Alzheimer's and Related Dementias Task Force, of which we are a proud member. There were about 3 or so million people in Georgia who were over age 45. 13% of that population, people in Georgia over age 45, believe that they have symptoms of cognitive impairment. Remember the symptoms that I just showed you. We're talking about really severe, really meaningful changes. 13% of the population, if you ask them, says, actually, I have to say, I've started to notice some changes in these areas and they worry me. And yet, 80% of those Georgians who self-report having some cognitive impairment have not talked to a doctor about it. Now, incidence of Alzheimer's disease tends to be higher in Georgians with lower levels of education and lower access to healthcare. So, north to south in our state, people are not talking about their cognitive health. They're not discussing it with their doctors, and we have vulnerable members of our community who are in even more danger. So what are we going to do about it? Well, there are some barriers to working with folks north to south in our state. One of them is knowledge. A lot of times in the communities that we work in, there's a lack of understanding of what Alzheimer's disease is. We still sometimes hear the words old-timers disease. There is still a widely held expectation that all of what we told you about cognitive aging is actually not true, and that Alzheimer's disease is just normal, right? It's not the case. That is not normal cognitive aging. Now, we don't just see this in members of our communities who are in need of a diagnosis. We see this among the healthcare providers who are diagnosing them, who say things like, it's so stressful on the family. Yeah, it's probably Alzheimer's disease, but why bother stressing them out? There's nothing you can do about it. And that's the impression that I want to counter very badly. Now, there are cultural barriers. There is a mistrust of science and medicine in various parts of our state. In fact, in a lot of it. There are language barriers and there is stigma. When we work in rural communities, one of our first questions is, what are the words we should be using to talk about this problem? What would resonate with you? What would your community find meaningful? And it varies from place to place. Sometimes we're talking about dementia. Sometimes it's talking about Alzheimer's disease. Sometimes we're not, though. Sometimes we're just talking about brain health because the words can be scary and invoke stigma. Now, the mistrust of science and those language barriers when it comes to understanding science, that's a really, really big issue. Now, we also find barriers when it comes to infrastructure. To diagnose Alzheimer's disease confidently, right? One needs to have a really thorough medical workup done, a good medical history, a medication review. Senses need to be checked. Really nice, thorough neuropsychological assessment needs to be conducted. We need labs to make sure that we are, ruling out other issues like, say, B vitamin deficiency or undiagnosed syphilis. And we absolutely, in many cases, need neuroimaging. We need to see what's going on from a pathology perspective in the brain. So a lot of the places where we are, there is no MRI, there is no access to a PET scan. And within our entire country, there is a lack of specialty care in rural Georgia. in rural Maine, in rural Wisconsin, in rural Montana, right? In the United States, only about 8% of specialty care providers actually practice in rural communities. And then, of course, there are economic issues here. Insurance does not cover a lot of what we need to do in order to give you a diagnosis of Alzheimer's disease. So let me remind you that when we start talking again about Grandma Evelyn and Grandma June, we made a promise. And that promise was to do better, to be worth the trust our families instilled in us, and to try to make a solution for Georgia that maybe, just maybe, we can extend to the rest of the country through similar mechanisms. So this is our strategy for turning passion into action. Welcome to the CARE initiative, right out of here, the University of Georgia. So when we talk about CARE, that acronym is for Cognitive Aging Research and Education. I'm in this building right now speaking to you, and I am deeply proud of our infrastructure here. Together, we are forging a new pathway to living with dementias. We, the Care Center crew, exist to provide and improve access to diagnosis, education, and support for those who are at risk for or living with dementias. So I mentioned 3 pillars there: education, diagnosis, and support. Let's break each of those down for a few minutes. When it comes to education, I think one of the first things that we tried to do was plaster the universe with Alzheimer's disease education. You have likely noticed some Alzheimer's Association materials embedded in our slides. We have wonderful partners in the Alzheimer's Association and absolutely love those relationships. We have taken to the national stage, the international stage, and even the TED stage to talk about these issues that we think are so deeply important. Now, part of education isn't just educating the community, it's educating our healthcare providers. In this particular picture, I'm in Singapore talking to doctors about brain health, but we do this all over the place. In fact, one of our big goals is to develop and accredit a CE and CME program for any healthcare provider anyway, to talk about how to diagnose dementia and why it's meaningful to do so. What sorts of benefits exist to people that only come with diagnosis. We teach our students and we teach our community. And in fact, we teach our students to go out and teach in the community. So education is really central to what we do. One of our goals is to create well-informed communities by using materials that are tailored to the needs of those communities. And we'll talk about that process momentarily. Now, our second pillar is access to diagnosis. It is not the case that specialty providers practice in every single one of our communities. However, the University of Georgia is the state's flagship land-grant university, which means that UGA is present in every single one of our communities, as is access to stable, reliable broadband through those extension networks. So in addition to building a physical clinic right here in Hudson Hall on the campus of the Health Sciences here at UGA, we also tend to find creative ways to reach out to folks across our state using telehealth. And I'd like to re-reference, Janae's engineering psychology background as she has this expertise and has kindly decided to fulfill her side of this promise right there in that sort of focus on technology. Now, of course, the last thing we want to do is to provide a diagnosis and say, good luck. Very often when we are in our communities asking people, what was your experience like? If we meet with someone who's gotten a recent diagnosis and we say, what was that process like for you? The most common word we hear is cold. That is perhaps the worst word I could ever hear attached to a diagnosis of something like Alzheimer's disease. So we are developing and tailoring support materials for all of Georgia's 159 communities that tell people where they can go right in their own community to receive support. We are empowering clergy and faith leaders, community representatives, anybody who is empowered enough to want to join this cause, to learn how to help provide support to those who are in need. In other words, if you're catching a theme through all of this, here at the University of Georgia, we have a research-rich environment. We have specialists, we have technology, but it's not going to make a dent in our state and the problems that we all face if it is not deployed where it is needed. So we have partnered with Cooperative Extension. We've partnered with the University of Georgia Archway Partnership and with others throughout our state and our Department of Public Health to turn the CARE model into reality. So where are we with that? How are we doing? Well, we began in 4 of Georgia's thriving, wonderful rural communities. So you're looking at Grady County, which is right down there on the Florida line. You're looking at McDuffie County and Hart County, and Washington County as our four first communities that we went into. And the process is simple. It's simple to understand, perhaps not to execute. We'll get there in just a minute. Because we have the University of Georgia Archway Partnership, we have Archway professionals in each one of these counties, and each of these counties are special. They have all asked the University of Georgia to partner on some sort of economic development initiative. In many of our counties who join our Archway Partnership, health-related issues, health-related infrastructure is a big economic issue in the community, which gives us a chance to go in and try to understand a little bit more about how the community is currently dealing with Alzheimer's disease. Now, in each of these communities, we form a working group. These are individuals within our communities who have a passion for this problem. In one of our communities, it's a former mayor, right? We have volunteers, people who cared for loved ones, who are right there with us, people who have industry-based connections to this problem. Maybe they work in assisted living, or they run, elder care establishments. Whatever it is, we all get together and we talk. We at the University of Georgia listen. We figure out what's going on, and the county works with us to make an action plan. Now, once we have that action plan, we can start deploying education resources. We can start deploying, technologies for improving access to diagnosis, healthcare provider education and support services, all tailored around what the community needs and eventually owned by the community. In order to tackle this problem, it can never just be the University of Georgia goes in and tries to solve it, right? This has to be from the community up. So if we were to ask the question, how is it working? I would love to show you that. So far, we are in all of these various communities and expanding our approach. We're getting phone calls every day from folks in other communities who want to join in the initiative and really want to try to make a difference here. Because every good story needs a good ending. And in our case, we have not written a tragedy. Our goal in our tale of 2 grandmothers is to take what we learned from our families and make sure that everyone we meet has access to those services. Every community addresses the problem differently. We don't have the same strategy in Hartwell, Georgia that we do in Sandersville. We don't have the same strategy in Thompson that we do in Cairo or that we do in Statesboro, right? But when we get together and try to work on these problems as a team, when we think differently, we find that we can write our own book. We do not need to be bound by the tragedies that we've heard in the past. We are capable of making a different story. It's a very University of Georgia story. But since every state in the US has a land-grant university, I think it's going to be a story that is told often. If you listened today, and this is something that you're struggling with, if you are concerned that you or a loved one is at risk and needs help, please reach out to us. You can find us at carecenter@uga.edu, or you can feel free to call us at 706-542-2539. The Torrance Festival of Ideas is all about creativity. It's about looking at problems differently, about seeing things through a different lens. Janae and I very much hope that you enjoyed seeing our take on taking an intractable problem, something that feels so big and so impossible to solve, and putting a little bit of creativity into the solution. Thank you very much for taking the time to view all of this, and please feel free to reach out. If you have any questions about what you've heard today, this email address will get you right to us. Thank you for your time.